talks. And so we're going to invite first Angela Fitch from Boston, who's joining us to discuss managing GI side effects and preventing discontinuation of GLP-1 therapies. Is it all the dose, or can we leverage diet to build on our guideline? Angela.
Thank you so much for having me. It's a pleasure to be here. Thank you to John and the other organizers for inviting me. It's my first time at this conference. As a physician who mainly does clinical medicine for the past 20 years in obesity, treating obesity way before we had GLP-1 based therapy. So using a lot of different techniques over the past 20 years. It is a thrill to be here with so many different people, doing the research, around this. So as Luke mentioned, I am going to talk about specifically some of the GI side effects that lead to discontinuation. These are my disclosures. And as Luke mentioned, recently this nutritional priorities to support GLP-1 therapy also came out. So again, this was our joint statement from the American College of Lifestyle Medicine, the American Society for Nutrition, Obesity Medicine Association, and the Obesity Society. I'm the past president of the Obesity Medicine Association. I was not intimately involved with this, but we did review it and approve it as an association as the board of directors. So again, I'm going to focus directly on the management of gastrointestinal side effects of this piece, and we're going to go into that in some detail. But again, I will preface this to say that we do not, for the researchers in the room, right, what we really need today is much more research around this topic, because a lot of what I'm going to talk about is really sort of expert opinion and anecdotal evidence, right? My experience over the past 20 years of prescribing GLP-1, right? We had GLP-1 back in the early days of exenatide in treating my primary care patients. I'm internal medicine and pediatric board certified, as well as obesity medicine. So, in using these medications, these therapies for the past 20 years, certainly, have learned a lot from my patients themselves, right, about how to manage some of these side effects. So if you look at the most common side effects, right, that we have to deal with, we have nausea, constipation, and diarrhea, at the top. A little bit less common, vomiting, eructation. We're going to talk about that a little bit because I find that one of the most fascinating side effects that we need to try to manage. Abdominal pain, gastroesophageal reflux disease, and then less common side effects, but still, very important to our patients, is cholelithiasis and then pancreatitis, which we'll talk about a little bit. And cholelithiasis in particular, because again, if you look at some of our clinical trials, and especially the patients that come to me at our clinic, we have a longitudinal chronic disease-based model clinic set up to design to treat patients in the United States for metabolic disease as well as primary care. So our clinic is virtual in 50 states across the country, as well as we have in-person clinics in Boston, Dallas, Chicago, soon to be New York City, Atlanta, and San Diego as of early next year. So we are going to potentially have the largest database of patients in a real world setting in one clinic, going through therapy. 60% of our patients at KnownWell are on GLP-1 based therapies. So again, these sorts of side effects are very important to those patients when they affect them, right? So if you look at SURMOUNT-5, so SURMOUNT-5 was just recently published in the New England Journal here. And SURMOUNT-5, I know this is really tiny there at the top, but was a pivotal trial because everybody in the trial got therapy, right? There was no placebo arm. This was a trial looking at tirzepatide versus semaglutide. And you can see in that tiny red box there, the common side effects, with most of them being gastrointestinal at the top, right? The nausea, the constipation, the diarrhea. So about 40%, about equal as it relates to nausea. As far as constipation, same, a little bit, potentially less in the tirzepatide group, potentially the same as far as diarrhea, maybe a little bit less vomiting noted in the tirzepatide group as well. And then as you look down through the rest of those side effects, you will see those other ones that I talked about, the eructation there at about 10% of people, the abdominal distension, abdominal pain as well, as the gastrointestinal reflux disease, dyspepsia, et cetera. So again, when we look at this, we have a common side effect profile that is particularly about the same between the two groups, but managing these in particular is what's going to be helpful in terms of keeping people on therapy. As was mentioned by Luke, patients do tend to go off therapy over time. So we also wrote earlier before that consensus statement, or before our consensus statement, and before the other work that was done by multiple societies, we got together and wrote this article. I was one of the authors of this article, Nutritional Considerations with Anti-Obesity Medications. We felt strongly that we needed to come out with an article about these nutritional recommendations because we have a lot of nutritional recommendations for bariatric surgery. And now we have, with our more highly effective anti-obesity medications, we're reaching similar sort of outcomes as we did with bariatric surgery. So we felt a need to come together and make some expert recommendations. Again, this was not a modified Delphi approach. This was just us coming together, looking at the literature and putting forth some ideas. So very similar to what we wrote in the Delphi consensus statement, doing that assessment, doing those recommendations on fluid, protein, fiber, energy, micronutrients. And more importantly, looking at that, what I was designed to talk about today is the management of these associated adverse GI effects with dietary approaches, right? In particular, eating smaller, more frequent meals, limiting high-fat foods, spicy foods, alcoholic or carbonated beverages, dose reduction, of course, as was talked about, and then OTC medications or prescription medications even to manage those side effects, and then ensure that patients are getting adequate protein, fiber, fluids, micronutrients in order to, really hopefully help them to do this in the most successful way. So breaking these down a little bit, from a nausea standpoint, I think clinically, the one thing that we tell patients quite often is do not forget to eat. Because many of our patients on these therapies will just literally say, I just forget to eat. I don't want to eat all day. And again, when that happens, people are going to get more nausea because of some of the ketosis that happens with that, sort of dietary pattern, right? That could drive more nausea related to the disease state. We see this nausea as more like, I think, pregnancy-related nausea, right? Where people feel a little bit better when they get a little bit of something in their stomach. So patients often in the morning will say, I feel, my stomach is upset. What do I do about that? And eating something can be helpful. We do use antiemetics in our clinic as well, to help patients as well. And then I think we should also look into some research around non-pharmacological therapies, such as ginger, acupressure, some of the other types of therapies that certainly women have used for years. Again, we don't have a lot of data around that, but we do have a lot of patients using these types of treatments. From a constipation standpoint and diarrhea, which is, again, one of the bigger things, I think the thing that we say most in our clinic is that fiber is your friend, right? We have constipation where both insoluble and soluble fiber can be helpful, fluids, hydration, as was mentioned, 14 grams per 1,000 calories in the diet. And then from a diarrhea standpoint, I think, managing that can be a little more difficult in clinical practice and is a reason that patients do tend to discontinue more than patients who maybe have constipation, meaning I feel like it's easier to manage the constipation a bit versus the diarrhea. So this is where we need much more research into how can we help our patients, right? But we do talk about avoiding caffeine, avoiding fatty foods, potentially avoiding dairy if patients might be sensitive to that, reduce artificial sweeteners in particular. And then the real question too would be, is there a role for a low FODMAP type of diet, for those patients that are having diarrhea, with these types of therapies? And we don't know that, again, but we know from other diarrheal research that can be beneficial. If you look at gallstone risk, right, we know that there is a risk of gallstone formation with obesity itself, with rapid weight loss, right, as far as our patients with bariatric surgery, diets that are low in fiber, people with inflammatory bowel disease, metabolic syndrome, insulin resistance, diabetes can also increase gallstone. So you see there's a distinct overlap, right? So our patient population in general, who happen to be mostly female, fertile, fat, and 40. That's what I remember from medical school, are the people that get gallstones, right? That's how we learned, how to remember someone that gets gallstones. 70% of our patients that come to our clinic are women, and the average age of our patients is around 50. So again, we have a high-risk patients for gallstones, so helping them to manage that can be interesting. Now, here's a study from way back in 2013 that did look at the risk of gallstones with a VLCD versus low-calorie diet, showing that there was a threefold increase in stone disease on a VLCD versus the low-calorie diet. That number needed to harm for stone disease was treating about 92 patients, and then 151 for a cholecystectomy, so a little higher for a cholecystectomy. And if you look at some studies around gallstone prevention, actually, and this is fairly old data from 2014, I find it fascinating as a clinician. We haven't put very much research into gallstone formation, but in here we have a study looking at ursodicholic acid, versus actually olive oil. So in that study, there was actually no difference between ursodeoxycholic acid and olive oil. So 1 teaspoon of olive oil a day was equal to doing ursodeoxycholic acid. And the number needed to treat was 9 for stone disease, preventing stone disease, and 15 for cholecystectomy. So a fairly low number needed to treat to potentially recommend that. So we do talk to our patients, about making sure they include some healthy fats in their diet and don't sort of just run around eating, lettuce and chicken, for example. And why do our patients stop treatment? In this real-world discontinuation study of GLP-1 receptors in patients with type 2 diabetes even, right, GI side effects were the most common reason. And I think it's important to manage these side effects with dietary counseling in particular, with medications, and then, of course, dose titration. And really, anticipatory guidance is key. In our clinic, we have 81% persistence on GLP-1 therapy at 1 year. We have over 20,000 patients that are, in our clinic profile right now. And as I mentioned, about 60% are on GLP-1. So we do not have the same data of everybody going off these medications at 1 year. And the reason we have that is because our patients see a dietitian, our patients see a health coach, our patients get a lot of follow-up, monthly follow-up, and then 3 months follow-up. And so again, with that sort of anticipatory guidance, I think you can manage these side effects effectively to keep people on treatment. And this is the one I want to challenge you all, if you're doing research, to really try to look into a little more, because it does really affect our patients a lot. And that is that eructation or burping, right? And in particular, these burps tend to be sulfur-based, meaning patients come in complaining of sulfur burps. I am burping sulfur, and that is disgusting. It's disgusting to those around them. It's disgusting to themselves. If you're a 25-year-old person trying to go out on dates and other types of things, it's not good if you're running around, smelling like sulfur. And again, these are just some theories that have come up in research, right? Is it the medication-induced delayed gastric emptying? That sort of gastroparesis research shows us that sometimes patients with gastroparesis have this side effect as well. Is there fermentation occurring? Does it happen more, for example, in patients that eat a larger meal later at night, such that that food is sitting around more throughout the night? Small intestinal bacteria overgrowth is another sort of, issue. Do these patients have more of that? Should we be really looking for that in these patients that complain of sulfur burps? And then, a diet rich in sulfur containing food. Should we be advising people that get this sort of side effect to eat less of these sulfur containing foods? I think that is a question to be determined by research. And then lastly, as Luke mentioned, this was our consensus statement from our international guideline that we have put together. And again, looks at sort of in patients experience nausea and vomiting, we should obviously monitor for those symptoms. We should obviously treat those symptoms, adequate proper hydration. We actually prophylactically prescribe ondansetron in our clinic for our patients to have on hand in case they experience nausea or vomiting, so that they don't have to go to the ER or to the emergency room or to the urgent care, in order to get treatment, meaning we don't tell them to take it, but we give that to them so they can have it on hand, in case they do have these symptoms. And then again, diarrhea, especially, managing that symptom, and then constipation, being the biggest symptom. And certainly, when patients are eating less food in general because their appetite is reduced, whether that's with a GLP-1 based therapy or with other anti-obesity medications, helping them to understand that they're not eating as much. And if they're not eating as much, they're not eating as much fiber. So they really do have to focus on that fiber. And lastly, in the 5 A's sort of model, I developed my own 5 P's. And again, I did this for clinicians as I've been teaching them for the past 20 years. How do you do nutrition therapy quickly in a 3-minute office visit? Because again, I think as medical doctors, we didn't get a lot of nutrition therapy. And so if you can remember it on one hand, it's actually more than 5 P's. I had to combine some because I wanted to get to 5. So it's planned portions. So the idea that you need to plan your portions with regular, consistent eating, plants and protein, right? So every time you eat, say to yourself, are you eating a plant? Am I eating a protein? If the answer is no, then maybe consider, adding one of those in there. Because again, patients are overwhelmed by the amount of information that is out there on the internet. And I just tell them, right, it's really easy. Every time you eat, am I eating a plant? Am I eating a protein? And then power for strength training. That's me over there in the gym doing squats. And then pillow for adequate sleep, meaning, we should sleep like a baby, right? And we should focus on that sleep and really prioritize that. And then pause for the idea of sort of, fasting throughout the night. And so again, thank you so much for having me. I think the more, as was mentioned yesterday, the more we can develop really actionable things that patients can use and physicians can use in the clinics to be able to help our patients manage these side effects, the better off patients are going to be in the long run, and the better, the happier that we're all going to be, and the less we're going to have to, answer all those phone calls. So thank you so much. Let me just stay.
Thank you. Thank you, Angela, for this nice overview and the advice and practical recommendations that can be used by many physicians. In the same context and in the same field on nutrition and GLP-1 therapies at the intersection, the next speaker is Andreas Pfeiffer, who will now deal with the key issue of lean body mass. We know Andreas already many years as an EASD important person who has done a lot of work in organizational aspects at level of EHD and DNSG, and he's actually working at the Charité in Berlin. Andreas, please.
Thanks a lot, Luc. Thank you very much for inviting me here. It's a pleasure to be here once more, although I only have a 25-year history of coming here. Okay, lean body mass. We heard a lot about protein intake, and I will try not to go too much of what we have already heard. I think it's clear to everybody that muscle is a very important organ. The myokines, the molecules produced by muscle and the regulation of muscle is a topic which is becoming more and more obvious, and the importance of being physically active is clear actually to most people. But doing it is another thing, and that's something, well, where you really have to take a decision. We also have heard and know very well that loss of muscle is one of the topics which is coming up and which is discussed a lot in the context of weight loss and extensive weight loss induced by the GLP-1 and agonists and GLP-1 GIP co-agonists at present. And you see here the approximate number from a brief comment recently, which was recently published in JAMA. So usually it's around, as we heard from Dr. Nieland yesterday, 25%. And he has also published a very nice paper with Andreas Birkenfeld about that. Now, is a loss of fat-free mass really a clinically relevant problem? So sarcopenia is clearly associated with many negative effects like frailty, falls, osteoporosis, fracture risk, loss of independence, increased mortality, cardiovascular disease. So that's something to be avoided. The problem across the studies is that the definition of fat-free mass or muscle, lean body mass, is quite different. And so the ways to measure it were vary between DXA, MRI, body plethysmography, the BOT-POT, underwater weighing. And so it's difficult to compare different studies. Sarcopenic obesity is the upcoming problem, but if you look at the literature, estimates of the prevalence of sarcopenic obesity vary between almost nothing and 80% in obese people. So there are many controversies around. If you look at what is most frequently and simply used is bioimpedance analysis, and you correlate that with MRI determinations of body composition, which is probably the most precise at present to assess muscle mass, you can see the correlations are relatively moderate. The numbers here are for obese or non-obese people. And actually in obese people, which is more the black symbols, the correlation is 0.5, 0.56. So it's okay for clinical use, but it is not precise if you want to use it in a study. Now, if you look at the loss of lean mass in one of the studies, very nicely discussed here by Locatelli and co-workers from Italy, there was a 23 kilogram loss with tirzepatide over 72 weeks. And this was 17 kilograms of fat mass and 6 kilograms of lean body mass. Now, what is lean body mass really? This was also very nicely dissected by Timsley and Heimsfield. And you see on the left, the skeletal muscle mass is composed of quite a bit of water and protein and also some fat, this dotted line which goes over to the fat. The fat-free mass is also water, protein, and residual mass, which are other components. Even fat has 15% protein. So if you lose a lot of fat, you will also lose 15% of protein. And now if you apply that, you see fat-free mass in blue is 6.9 kilograms lost here. Skeletal muscle would be 4.2 kilograms. But if you correct that for water and actually skeletal muscle protein, you end up with 0.7 kilograms. So the question is, how relevant is that for people, who are healthy and for people who have problems, who are sarcopenic? If you go across studies and you correct, this is by an algorithm which was developed by Professor Müller and Bosi Westphal in Kiel in Germany, you actually get lower numbers of lean body mass loss across the different studies, but still you have a wide variation. So some people claim that the losses of fat-free mass with semaglutide and tirzepatide are quite different. Actually, in the SELECT-5 study, I didn't find that data. That would be a nice comparison. But this is certainly not clear at present. The other argument is if you lose weight, 10 kilograms, I mean, if you carry your bag up the stairs with 10 kilograms, you know what you need as muscle to carry that. It's adequate to have less muscle. So, and in fact, the quality of muscle also improves. There is loss of the myocellular lipids, the fat in the muscle quality gets better, insulin sensitivity gets better. You do not see effects on strength with the loss of muscle around 10, 15 kilograms in most studies which looked at that. Unfortunately, FDA does not request any studies about muscle quality or protein in their in the trials. So this was not tested in general. So if you ask what is the balance of benefit on HbA1c, body weight, reduced risk of cardiovascular disease, kidney function, and on the other side, harm, loss of fat-free mass, there's perhaps more retinopathy and frailty in old people. What is the balance? This is probably what we should look at in our patients. So actually the prevention or the way to prevent sarcopenia with these drugs has not been studied so far, and we are missing studies as we heard before. So do the different incretin agonists differ? So this is also unclear. Now, what can we do? Protein intake. We heard that we recommend more protein intake, and how well is that argument actually backed by data? If you look at populations, so here this is a study in 70 to 79-year-old people, and I guess loss of muscle is mostly relevant in old people because of the genetically programmed loss of muscle mass. You can actually see that people who eat more protein here in quintile 5 lose less muscle. So higher protein intake is effective if you look at some studies in populations, and the amount of protein intake was between 10.9 and 18.6% of energy intake. So a little bit more protein is probably meaningful for older people. Further, some papers now come up which say that the distribution of protein over the day should be high. So each meal should have something like 30 grams protein. Usually people eat breakfast with more carbohydrates, the nice stuff we got this morning, this little muffins and so, and little protein. If you distribute the protein more evenly, it looks like the muscle protein synthesis is better over the day and you may maintain muscle better. But this is also very little studied, quite preliminary data. There are many studies actually about protein intake combined with exercise. There is very little about only protein. And as we heard, probably protein alone does not have so much effect. We actually saw if we have 30 energy% protein in our studies on weight maintaining people, that there is an increase of about 1 kilogram with animal protein. We didn't see that with plant protein, even though they had the same amount of protein. And then you can supplement with leucine and so on, which does have effect. There are many studies which use different combinations. But if you look at people here with diet of high protein 2.4 versus 1.2 grams plus exercise over several weeks, then you do see an increase in muscle mass of about 1 kilogram compared to the control group, which did not lose muscle mass. And this was combined with weight loss of about 4 kilograms. And you see the weight loss was a little bit less because it was an increase in lean muscle mass. So it is clear exercise plus protein has a small effect on muscle mass. If you look at strength, there was no effect. Then if you, this is a meta-analysis of many studies. So on the question of how much protein intake do you really need? And this was the group with 1.6 grams. Down you see this little symbol. So it increased to some extent in those 25 studies. If you go between 1.2 and 1.6 grams, you have a smaller increase. And if you are around 1.2 grams, there is no increase. So you need something which is probably above 1.2 or 1.6 grams of protein to really have an effect. Now, the one study which looked at that in more detail has already been shown briefly by Luc, by Lundgren and co-workers from Denmark. And they first made the people lose their about 15, 16, 13 kilograms of weight. And on the right side, you see these yellow bars. They lost, the dark yellow is fat mass, the light yellow is lean mass. So they lost around 5 kilograms lean mass. And then after that weight loss by diet, they received either liraglutide or exercise or both. And those are the lines you see there. The blue line is liraglutide, which caused a little bit more weight loss. And then you see on the right side, the liraglutide, the blue bar, there was a loss of weight, but not of muscle mass, a further loss, but they didn't recompensate in any way. If you combined exercise plus liraglutide, they lost more weight. And they had a small increase in muscle mass, but you see this is a few grams, actually. And exercise alone actually was more effective. So the greater weight loss caused by the liraglutide also did not or blocked somehow the muscle protein synthesis of about 1.5 kilograms. Now, interestingly, this was followed up another year. And if you look at that follow-up, you can see, well, people regained weight, and only the group who had exercise maintained actually the weight loss. So this is not about the amount of, they don't report protein, muscle mass in that second study, probably didn't measure it. So the effects of higher protein intake and exercise are good to maintain weight probably, and do have some effect on muscle, and exercise we know is very healthy, so we should always recommend it. There's no argument against it. But if you ask for the effect, it is not dramatic. And in this study, people did not compensate for the loss which they had with the weight loss before, neither after 2 years or, well, 2 years we don't know, but after 1 year. One of the problems is what happens, or weight cycling actually causes loss of muscle mass and causes increasing loss of muscle mass. And this is what you see here in these bars. So it's either 1 cycle, 2 to 5, or 5 cycles, which will cause a loss of muscle mass, and this will be associated with a loss of strength. So you do develop sarcopenic obesity with repeated cycles, and this is what we are likely to face with people who have to pay for the GLP-1s because they take it for a while, then they stop simply because of the cost, because they think they can maintain it, but they will regain weight, most of them, and will probably try another cycle. So this is a scenario we will see, which is going to happen. And now if you look at this study here, the risk of developing sarcopenic obesity is very likely to increase pretty much under these conditions. So this was without those drugs, so just people who did weight loss just by calorie restriction, but they also tested strengths then, hand grip strengths and stand up and go test. And this showed that it's a detrimental effect. So we really have to advise our patients to do exercise, which is the most effective way to maintain mass, and then to combine that with sufficient protein is certainly a good recommendation, and we should also go for that. Now, if you look at this correlation, and we saw a similar graph by Dr. Nieland comparing different ways of weight loss. The more weight you lose, the more muscle you lose. So far, we cannot really prevent that. And so we need actually really strategies if we get up to 25, 30 kilograms with future drugs to maintain the performance of people, especially when they are old. So we will see how that works. What is coming up now are the substances to stop muscle loss. And this is achieved by the activin receptor antagonists, if you block those receptors. And so we can reduce the myostatin activin pathway activity. And this is very interesting because this was a study which didn't have a GLP-1 or so agonist in it. Just this compound alone caused a loss of, as you see here, about 6 kilograms. And while the lean mass was increased. So far, we only use this pathway to breed cattle to get more muscle, but perhaps in the future, which are knockouts, of course, but in the future, companies are already testing this. This is actually a graph from an ongoing trial for combination with GLP-1 agonists, and maybe you can put both into one syringe. This was injected once every 4 weeks in that study. So if we conclude weight loss is proportionally linked to loss of lean body mass, according as far as we understand it at present, the relation of muscle function to strength is moderate. So for younger people, that loss of muscle mass is unlikely to be a serious problem, and they can, well, doing exercise and eating enough protein, they can compensate for that, and they will not become sarcopenic and dependent. Comparative studies of incretin agonists and co-agonists regarding body composition and muscle function, risk of sarcopenia, weight cycling, potential preventive effects of increased protein intake are needed. We don't have a single study actually with protein intake, for instance, combined with the GLP-1 GIP co-agonist or agonist. Correlates with lean body mass in older individuals, so higher protein intake has good arguments and is probably effective. Exercise is probably the most effective way to maintain and increase muscle mass and function. And so this may be enhanced by protein intake a little bit, but so we should really find ways to get our people to do exercise, because we know that in general this does not work. And we will hear more about it, I think, in the upcoming talks about apps and so to support that. And then the problem is probably the older and sarcopenic individuals. So if you really have the over 70-year-old diabetes patient and you want to give him these drugs, how can you prevent the negative side effects? And does he really benefit from it? I mean, we heard from Herzl that many people have remission. We have the age-related diabetes and obesity-related diabetes in 50%, which is actually a moderate and mild diabetes. So if they have enough insulin, they can remit even spontaneously. And those people may not really profit too much because you don't prevent complications and the consequences of obesity in somebody who is 79 years old. So I think these are topics we have to discuss in the future. And I would like to stop with that. Thanks.
Thank you, Andreas, for this excellent review. Thank you so much. The lean body mass and muscle mass versus muscle functionality remains a critical issue and needed for further studies. It's in that respect, it is so pity that in all the large trials with SEMA, with tirzepatide, even SELECT, where we have data on lean mass, that nothing was recorded on nutrition or on physical exercise. That's a big pity for such large trials. Okay, so then we continue with the last presentation in this session, which is again Dr. Ian Nieland. He was already presented yesterday. He's a preventive cardiologist working at Huntington Heart and Vascular Institute. And you will give us the answer now, hopefully, whether GLP-1 therapies and diet and exercise can be additive.
All right. Well, thank you very much for inviting me, and I'm looking forward to taking this session home. So there are my disclosures. I think it's all, we all agree that lifestyle behaviors, even in the era of GLPs, remain the cornerstone of obesity management and are really recommended as a first-line treatment for obesity. Now, when we talk about lifestyle, it's a broad term, and we had heard a little bit about terminology yesterday. And so what we mean really is referring to changes in physical activity, decreasing energy intake, and behavioral techniques to adopt dietary and physical activity changes for the long term. Now, weight losses with lifestyle changes alone are typically up to 8% after 1 year, and then there's some recidivism with 3 to 5% weight loss sustained in the following years. A very low calorie diet or a low calorie diet often is very effective, as we've heard, and can induce 1 year weight losses of 7 to 10 kilograms. Exercise interventions alone without dietary modification is much less effective and typically result in modest weight losses up to maybe 4 kilograms. But there are potential improvements in body composition, such as reduced fat mass and preserved lean mass, which improves composition and also helps maintain weight loss in the face of calorie restriction. Now, importantly, exercise can do that and improve body composition with a long-term effect. So the question is, exercise may have a legacy effect beyond, let's say, stopping a program. The body may maintain some of that memory and body composition may be preserved. Now, we are in the era of GLPs, and GLPs, I like to say, is the gift that keeps on giving, because it's every other week that goes by, there's a new FDA indication or a new trial suggesting benefit for GLPs across the host of cardiovascular kidney metabolic syndrome components. We know that it reduces cardiovascular events, it reduces OSA severity, we know it reduces CKD events, reduces visceral fat, appetite, blood pressure, a host of metabolic improvements. We are also now in the era that we're no longer using placebo comparators, right? SURMOUNT-5, as Dr. Fitch mentioned, it was an active comparator trial where we compared tirzepatide to semaglutide, and you can see, which was very consistent with the other trials with placebo, 15% or so with semaglutide and 22% or so with tirzepatide, and improved waist circumference as well. And so this era of GLPs now, we need to learn a lot more of what we're doing, because I think the clinical station where we are is much ahead of a lot of the research. As we mentioned before, there are a lot of questions we don't know. So healthcare providers in the US, at least, wrote more than 9 million prescriptions for GLPs in the final 3 months of 2022. And quarterly prescriptions quadrupled between the times of 2020 and 2023. Close to 100 million US adults currently meet weight loss criteria based on pharmacologic criteria for therapy based on BMI, with the predicted cost burden, if we were able to prescribe and provide these medications to these individuals, over $600 billion. That's equal to the entire spend for US prescription drugs combined. So therefore, there's concern over use of these medications and how it's going to impact long-term health. And so there's concern, for example, how it may impact lifestyle modification, right? Are people going to still diet? Are they still going to exercise? Are they just going to take the medication and sit there and wait for it to work? So that's the question, right? Are diet and exercise still relevant to obesity therapy in the era of GLPs? Well, first, let's look a little bit about how lifestyle is incorporated into clinical trial design. Right, the clinical trials were performed not in the setting of sedentary, sit on the couch, do nothing, right? There was a specific prescribed lifestyle component to every single trial. And for example, in step 1, which was semaglutide, individual counseling sessions occurred every 4 weeks to help individuals adhere to a reduced calorie diet, as well as increased physical activity according to current guidelines. Similarly, in SURMOUNT-1 of tirzepatide, there were counseling sessions. There was 500 kilocalorie restriction per day, and again, at least 150 minutes of physical activity per week. So the trial populations, at least what the investigators sought out to do, was to keep optimal lifestyle, right? Guideline recommended changes for patients in the context of the medication. That is not always what patients can achieve and can maintain, but that's at least what the trials represent. So it's unlikely and not realistic for patients to think that they're going to achieve necessarily the amount of weight loss or the health benefits they may see without the background lifestyle modification that the trials incorporated. Let's take step 3 of semaglutide as a little bit of a case study. I think it's very, very interesting, very fascinating. So in this trial, for the first 8 weeks after randomization, participants received a low-calorie diet between 1,000 and 1,200 kilocalories per day as meal replacements. After that 8-week period, they transitioned to a hypocaloric diet, now going up to 1,200 to 1,800 with conventional food for the remainder of the trial up to 68 weeks. And at randomization, participants were also prescribed 100 minutes of physical activity per week, which increased by 25 minutes every month to reach a total of 200 minutes per week, which is very commendable. That's about 45 minutes a day. Now, during this 68 weeks, participants were provided with continued individual intensive behavioral therapy visits with a registered dietitian who continued to instruct them on behavioral strategies, diet, and exercise. So a very intensive program. So if you look, for example, at the first 8 weeks where patients were on a very low-calorie diet or a low-calorie diet, you can see that the curves start to separate between 4 and 8 weeks, and there's a little bit more weight loss in the semaglutide group compared with the placebo group. So even though both groups were prescribed a low-calorie diet, weight loss was greater with semaglutide. Now, whether or not that's because with semaglutide, people even ate less than the prescribed amount, right? Maybe their caloric intake was less than the placebo group, even though they were prescribed already 1,000 calories a day. Or there's something else magical about the compound metabolically that can induce additional weight loss. But I think it's very interesting to note that even in the context of a reduced calorie diet, semaglutide can have continued effects with weight. So when the question of is diet additive to GLPs or GLPs additive to diet, I think at least yes from this study. The other point I want to make here is that clearly a low-calorie diet is effective. Even the placebo group at the nadir of about 28 to 32 weeks had an 8% reduction in body weight loss, whereas semaglutide had about double that at 16%. So certainly dietary changes are effective. Now, Dr. Pfeiffer stole my thunder a little bit because I think the best trial and best evidence we have to answer this question of diet and exercise additive to GLPs is the S-LIGHT trial that was shown up earlier. This is a randomized double-blind placebo-controlled trial of 215 adults with obesity who underwent 8 weeks of a very low-calorie diet, 800 kilocalories per day, followed by 52 weeks of treatment with either placebo, liraglutide, exercise, or liraglutide plus exercise combined. The exercise intervention did include a dedicated instructor and supervised group exercise sessions and heart rate monitors. Obviously, interventions that are not always feasible for most patients, especially those of low socioeconomic status and cannot necessarily join gyms with trainers and things like that. So it's a little bit of pie in the sky exercise intervention. Nevertheless, the trial did show that the combination of liraglutide and exercise led to superior weight loss maintenance and improvements in body composition, right, compared to either intervention alone. So you can see here that in the top graph, right, once patients lost weight with the very low calorie diet, which again was effective, the placebo group then started to regain that weight. Those individuals who had maintained exercise maintained the weight loss, but didn't necessarily lose any more weight, which again is what is expected from prior data. Liraglutide, as expected, as being a early generation GLP, had some weight loss additionally. And exercise was actually, in addition to GLP, was able to augment that further with additional weight loss. So again, this showed very clearly that exercise plus GLP is better for weight loss than GLP alone. And also, as was discussed, that improved body composition as well. There was much greater loss of fat mass and maintenance and even gain some of lean mass with the combined liraglutide exercise group. What was also shown from this trial was that what we call visceral adiposity, in this case was android fat percentage, and that's kind of a surrogate for visceral fat, was reduced more so with the combination therapy of exercise plus liraglutide than with either exercise or liraglutide alone. Now, I think it's also important to understand that exercise in and of itself, even if weight didn't change, right? I'll go back 1 second, right? Weight was stable, but android fat percentage was reduced. So you can reduce visceral adiposity through exercise interventions, even without weight change. That's a very important point. Secondly, that GLPs do reduce visceral fat as well, as I'm shown in this trial, as well as a trial that we did when I was in Texas several years ago. And so it's really important also to note that with that reduction in visceral fat, you see also a reduction in inflammation. So here, the investigators measured high sensitivity CRP, and there's some improvement with liraglutide, some improvement with exercise. But again, exercise plus liraglutide have the greatest benefits for reducing inflammation. So is it additive? I would say certainly yes. Now, what's fascinating about this trial is that after 1 year, they stopped the intervention, right? And they wanted to know what was the natural history and were there legacy effects of these interventions on this population going forward. So no surprise, right? Patients regained weight. Now they didn't regain back to where they previously were, and that's consistent with what we've seen with, for example, the trials in the STEP and the SURMOUNT programs. Those who had exercise had a little bit of a slower weight gain than those who were on placebo, right? So there's potentially a legacy effect there, as we mentioned before. Liraglutide, the slope of weight gain was much faster, right? This is both concerning but not surprising because patients often ask me, right, what happens if I stop the medication? And it's not surprising that if you don't take a medication, it can't really work. Unfortunately, that weight regain slope is very quick, and there seems to be no legacy effect when it comes to GLPs and weight gain. Whereas with exercise, you can see here, again, that slope was a little bit flatter, and the ultimate absolute change was less compared with the other groups. So again, I think that if you can add exercise into your GLP, and you can add a little bit of a low-calorie diet, which is not as hard with GLP, right? That's more of a built-in situation, then you will have definite benefits. The other thing that comes up a lot of times with GLPs, and I think this is what I would call a side effect, and I think you refer to this as well, Dr. Fitch, that fatigue, not enough fuel in the tank, can't really, don't feel like doing much. So the problem is that it's unclear whether that's a function of just not taking enough food in and forgetting to eat, and therefore you just can't, you don't have gas in the tank, you can't drive the car. Or if there's something else, right? Is there something going on in the hypothalamus? There's something going on in the brain that alters, pleasure centers, alters, brain chemistry such that people maybe don't want to be as physically active. Now, this is a very interesting study that looked at self-reported, mind you, activity when it came to placebo versus exercise versus liraglutide versus the combined exercise liraglutide. And what you can see is that now there's quite a bit of variability, but after 1 year of treatment termination, the participants who had received exercise alone or in combination with liraglutide had the highest reported levels of moderate to vigorous intensity physical activity. Amazingly, those who are on liraglutide alone had potentially higher time sitting and less time of self-reported physical activity. So the medication by itself, right? There was a little association, at least, this is not necessarily causal, but association with being less physically active and sitting more. And then when you looked at accelerometer measured activity and sedentary time, again, there was quite a bit of variability and not much differences. So, definitely hypothesis generating to try to understand that part of the counseling we need to do for patients on GLPs is not just to consider, exercise, but actually consider to increasing their physical activity in less sedentary time, because maybe patients will feel more tired, they won't feel like getting up as much, especially if they're on eating and things like that. So I think very interesting data. Lastly, I'll talk about how GLP-1s potentially impact dietary consumption and food preference, as was touched upon earlier as well. In this study, they looked at, it was basically a combination study of 10 different studies looking at caloric intake that was reduced compared to placebo treatment, right? No surprise that GLPs would do so. And, some of the limitations here was that there was some heterogeneity in how they actually collected the data versus 24-hour recall versus ad libitum. Only one of the studies described dietary counseling and guidance provided along with them, and just 4 of them evaluated changes in macronutrient intake in addition to total energy intake. And changes in macronutrient intake were really consistent among studies. So I think that from this, at least, systematic review, I think there's several unanswered questions still, right? How do GLPs and GIP-GLPs impact eating patterns and diet quality from micronutrients? Are changes in dietary intake associated with altered body composition during weight reduction? And what is the most appropriate dietary guidance for people taking these medications? So finally, I'll end up with this survey. And this was a survey done by researchers who surveyed consumer groups who were currently taking or previously taking GLPs. Okay, and they asked them, what kind of foods did you like? What kind of food preferences did you have? And what they found was that consumers currently taking a GLP consume significantly less calories than the other groups surveyed, right? As we would expect. What's interesting there is that it's about 700 to 800 kilocalories per day. And this is real world evidence. So I don't know if people have actually measured how many calories, people take in with GLPs in the real world setting, but it could be at this level. Makes sense. Additionally, those taking GLPs most likely reduced consumption of processed foods, sugar sweetened beverages, refined grains, and beef, all the bad stuff we've heard about for 3 days at this conference. Now, and you can see at the other end, right, it's called a waterfall plot essentially. At the other end, you see that fruits, leafy greens, and water was the greatest intake in terms of how people shifted their food preferences. Now, whether or not this is a function of the fact that people are taking GLPs, they want to become healthy, so they shift their food preferences to healthier preferences, or do GLPs somehow shift brain chemistry into not being as interested in certain type of foods, right? Feeling that nausea, feeling that, that queasiness when people think about like a big pasta meal with beef or something like that. It's really unclear. But what we do know is that if people can shift their food preferences to better foods, more nutritious foods on GLPs, well, all the better, so be it. So in summary, why do diet and exercise remain important even when taking GLPs? So certainly for long-term weight management, the combination of both GLPs and lifestyle can provide superior weight loss maintenance, improvements in body composition, and reduced inflammation. And GLPs can help with additional weight loss, but unfortunately will not prevent weight gain once the medication is stopped. And so lifestyle behaviors have to be part of the discussion when patients want to stop a GLP. I also will say that we need more data on strategies for GLP weaning or maintenance long-term, whether it's people doing it every 2, 3, 4 weeks at a similar dose, every week at a lower dose. There has to be data around that, and I think the research is ripe for that. Certainly, exercise and diet remain important to preventing muscle loss, as we've heard, and incorporating strength training is really important to maintain and build muscle while on GLP-1 medications, especially in folks who are older, where even older folks are trying to lose weight. I have patients who are in their 70s who ask for GLPs and are doing really well on it, right? And so it's certainly relevant to the aging population. And then improved overall health, obviously a healthy diet and regular exercise beyond weight can have myriad benefits, improving heart health, reducing risk for type 2 diabetes, and increasing energy levels. And finally, GLP-1 therapy without habituated lifestyle behaviors can potentially promote avoidance of exercise and a shift in dietary choices once the therapy is discontinued back to the Western diet we're all trying to avoid. Thank you so much.